part of the series, we'll be discussing on common pediatric endocrine emergencies. A 9-year-old boy was admitted in emergency following road traffic accident. He has traumatic brain injury, he was intubated and ventilated, and he was started on dextrose normal saline with 100% maintenance. He received 1 liter of DNS overnight and his urine output was 5 ml per kg per hour. On further assessment, the sodium is 156, normal potassium, normal renal functions. The blood glucose is 129 mg per deciliter and serum osmolality is 305 milliosmoles per kg. On further studies, we see that the urine specific gravity is low, urine sodium is 4 milliequals per liter, and urine osmolality is 100 millimoles, which is low. These findings are typical for diabetes insipidus. Diabetes insipidus refers to deficiency or insensitivity to antidiuretic hormone, leading on to impaired concentrating ability. This leads to passage of large volume of dilute urine, resulting in excess free water loss. The clinical features include polyuria, polydipsia, dehydration, and intermittent fever. Diabetes insipidus can be central or cerebral due to absent or decreased production, which can be idiopathic, post-traumatic or post-surgical, certain brain tumors or malformations, brain infection, inflammation, and infiltration can also lead to cerebral DI. Nephrogenic causes include acute tubular necrosis and certain medication which lead to insensitivity to ADH action. Commonly, following traumatic brain injury, a triphasic response in DI is noted. First, the pituitary stalk injury results in axonal shock leading on to rapid enlargement of anterior pituitary and compression of axon terminals of AVP producing neurons. This leads to an initial polyuric phase followed by axon terminal degeneration and uncontrolled AVP release, leading on to an antidiuretic phase between 5 to 12 days. Later, during the third stage, retrograde axonal degeneration results in death of cell bodies of AVP producing neurons, resulting in permanent diabetes insipidus with increasing polyuria. For the diagnosis, we need to have a clinical setting commonly seen in post-operative or brain-dead patients where there is polyuria, hypernatremia, serum osmolality of more than 300 milliosmoles per liter, urine osmolality of less than 100 milliosmoles per liter, and a low urine-specific gravity. Neuroimaging-wise, if the CT shows diffuse brain swelling and multiple contusions, or in the MRI, absence of hyperintense posterior pituitary stalk can also be considered as a surrogate evidence in order to make the diagnosis of diabetes insipidus. In any case of polyuria in patients admitted to the ICU, check urine osmolality. If the urine osmolality is high, it indicates solute diuresis. If it is low, it can be related to diabetes insipidus. A water deprivation test can easily differentiate between primary polydipsia and diabetes insipidus. Strict intake and output monitoring needs to be done, and fluids need to be individualized as per their sodium and osmolality levels. One may start with isotonic fluid and monitor the trend of sodium with these fluids. In acutely ill patients, vasopressin infusion may be helpful, and in chronic phases, desmopressin is useful. If you like these videos, kindly subscribe to the channel for more updates.